At the roundtable this week, with the concern nationwide over Ebola, are hospitals and health departments ready to deal with the virus? We're joined today by Dr. Kent Hall, Vice President of Medical Affairs at CVPH. Seated next to him is Dr. Gil Allen with Fletcher Allen Healthcare in Burlington. And we're also joined by Darwinna Facto with the Clinton County Health Department. Welcome to you all. Nice to have you here.
Thank you.
What steps are hospitals and the health department taking here to prepare for the possibility of treating patients who exhibit symptoms of Ebola or actually screen or test positive for Ebola?
Well, there's been a lot of work that's been going on, and a lot of work in the last, really ramped up a lot in the last 2 to 3 weeks. We have been identifying appropriate policies and protocols to put in place, which has been a little bit of a moving target as the CDC itself has been trying to figure out what is best, given the intensity of care that can be given in the United States versus what can be given in West Africa. So we have certainly been doing that. We've also been using our educational resources and getting volunteers within the hospital staff, both the nursing staff as well as the medical staff, in order to teach the critical people what we will need to do to be able to take care of these patients.
And you are hearing from both CDC, New York State, State of Vermont. Everybody, I'm sure, is weighing in probably almost daily on what you should be doing and what the protocol should be.
Yes, I would, and so Emory University has also now made their documents public. There's an 80-page document online. Nebraska, these biocontainment facilities that have had 10 odd plus years to really train and perfect these techniques have now made a lot of their documents public and are sharing them. And we're trying to cross match what they're doing with what we've planned to do. And as Kent mentioned earlier, that the 2 to 3 weeks ago, I think the episodes in Texas kind of, I think, really helped highlight just how ill-prepared many hospitals in our country were to deal with this crisis. And so a lot of us have really ramped up our preparation, and I think we've gone from almost 0 to 100 in the last 2 to 3 weeks. I think people in our hospital, I know in Kent's hospital, have been working 24/7 to make sure that our nurses and our doctors and the people that are going to be on the front lines feel as protected as possible. Fortunately, I think we took a step early on to say, look, the CDC's recommendations are a moving target. We're going to be as conservative and safe as we can and get the best protective equipment we can for our people and start training in them now. In case those recommendations change, we don't want to have to backpedal, and we want to make sure that our people feel as safe as possible.
Do you both feel you're ready?
We're getting there. I wouldn't put it out there of we're there, we're ready to take any patient that comes in with this. Going from 0 to 100 in a very short period of time, that it's going to be not only the initial training, but there's a constant retraining, refocus, reorientation, because it's very easy to lose that, to say, you don't have a case for a while. People start to say, oh, it's probably not going to happen. You never know when it's going to happen, so you have to always be prepared.
And let's talk about that briefly. Many people would think here where we are, northern New York, northern Vermont, that the risk is very low, and it most likely is. The probability is low. However, being as close as we are to the international border, to Ottawa, certainly Montreal, and with the likelihood that a number of colleges in our region have students that may be from West Africa, that increases the possibility or the probability that you may see a case.
That's absolutely correct. And what I will give a shout out to the staff at SUNY Plattsburgh. They've actually been very proactive with their students. They do have a number that are from Africa, and they've been very thoughtful, both in terms of taking care of the students, but also making sure that things are in place to protect the students and the campus environment itself.
Much the same for Fletcher Allen. Have you reached out to the universities and colleges?
We've reached out to the universities, the clinics, making sure that we're screening, that the proper screening questions are being addressed everywhere, so that we're making sure that if somebody's coming in with a fever that they haven't traveled to a West African country and whatnot. But looking at our preparation, and I think we just have to realize that the likelihood of an active case is probably pretty low, but the likelihood of a rule-out case is very high. We see somewhere in the neighborhood of 10 to 12 malaria patients at Fletcher Allen per year. They're not all coming from Western African countries, but they may be coming from Africa with a fever, and they'll be screened by our infectious disease doctor, and we'll decide whether or not we want to rule that patient out for Ebola. And we have to be prepared, and we want to make sure that we're handling those patients at the same level of scrutiny and safety as we would somebody with active disease.
And Darwin, let me ask you about Clinton County Health Department. How are you folks dealing with this?
We've certainly ramped up. Additionally, we had a lot of systems in place, surveillance, both active and passive. So much of this is what we normally do on a daily basis, so it's not new. We're just doing it to a higher degree now. Preparing, we've gotten a lot of information out to physicians' offices, so they know what to do if they have concerns, who to call, and where to go and what they should do with that person.
So everyone's awareness has been raised. Here's what you should be watching out for.
Correct.
Is the concern this time of year, as we get into flu season, that many of the symptoms can be very similar?
The symptoms can be very similar. The difference is travel history. Have they traveled to West Africa? We've actually made maps so people can point if they don't have good English skills, or they can spell the name of the country, because we do run into the problem where somebody might be in Niger, not Nigeria, and people get confused on that. So we want to make sure we have the most accurate information, so we decide if that person actually needs to be screened for Ebola or there is no concern.
Some of the guidelines and protocols are new, but all of you have dealt with infectious diseases before, and we've had a few threats and scares just within the past few years. We had SARS, and then we had H1N1, and so you have dealt with this before.
We do, and actually we deal with this almost on a daily basis with other conditions. You've got tuberculosis, even contact tracing through sexually transmitted infections. So the system is essentially the same, it's just a different organism. It's one that we have to be very respectful for, because it can be, people can die from it. So we need to be ramped up, be aware, have our systems in place for contact tracing, and making sure the public's aware of what they should do if they have concerns.
And at the hospitals, if you have a patient coming in exhibiting symptoms of Ebola, what are the steps you're taking now?
Well, at CVPH, what we're doing is we are following basically a 4-step process. The first is to identify the patient, and that's through basically just a couple questions. And then based on that, we isolate the patient. Then we care for the patient. I call it resuscitate if they are acutely ill, if they have serious problems, with their vital signs and things like that, then we address that. And then at CVPH, we're transferring as part of Fletcher Allen Partners and the network. We are lucky to have a tertiary care center as our partner. And with the resources at that center, we have decided as a network that we will transfer patients from the other facilities to the academic center, so that we can concentrate the intensive care to one area, so that we can make sure that we don't have to try and replicate things, that we don't have to replicate the education, training, and things like that.
So when you send the patient to the special unit at Fletcher Allen, are they only showing symptoms, or have they either screened or tested positive for Ebola? And let's talk about the difference there. Screening is when they're showing symptoms and they've been to West Africa. Testing positives is when you've actually been able to confirm that they have the virus.
Correct. And in our case, we are when they screen positive, so the testing hasn't been done, then we will transfer to Fletcher Allen, so that they can then do the testing as well as the care for that patient.
And Dr. Allen, tell us about the special unit you have set up.
So those patients will come directly to us. They will not go through the emergency department. We have systems set up in place to screen for patients coming into our emergency department. For patients coming to us, they will be brought to us with our special FAHC unit, the Fletcher Allen Coordinated Transport Unit. Those nurses and caregivers have been trained in the personal protective equipment donning and doffing process, and they're going through intensive training as well. They've identified a ambulance to bring those patients. They'll come directly to an area on our intensive care unit that's been wardened off and partitioned off to make sure that we're going through a proper staged donning and doffing of this personal protective equipment to make sure that people are entering the patient care area when they're fully protected and leaving when they're fully protected. And then there's a very complicated process of doffing and taking off the equipment where there can be self-contamination. So that'll be monitored by a buddy. And we're really trying to follow a lot of the guidelines that have been handed down from the CDC and by Emory.
Dr. Allen, at Fletcher Allen, are you prepared once you receive a patient in your special unit? Will they stay there, or will you immediately look to send that patient to a specialized unit such as Emory or Nebraska?
We have no way of knowing right now. The CDC has certainly promised that they would send a SWAT team, if you will, to whatever center has a confirmed case to help that hospital deal with the disease. These centers, like Emory and Nebraska, are certainly the best equipped centers to deal with active disease, and perhaps that's why they made the decision to take those affected nurses to Bethesda and Emory. But we have a lot of soldiers, and we have a lot of relief workers over in Africa right now that could contract the disease and want to come back to the United States for treatment. I still feel that those centers that have been training for 10 to 15 years are best equipped to deal with them, but if the numbers become a greater burden than those centers can deal with, we have to be prepared that those patients will stay with us. So we are making all preparations to make sure that we are able to care for them at our facility.
Is there a center here in the Northeast that specializes? You mentioned Emory and Nebraska and Bethesda in the Boston area, New York City area. Is there any?
No,
the four main biocontainment units are in Montana, Nebraska, Bethesda, and Emory.
And any word from the CDC if they may be scrambling to try to designate other medical facilities?
Again, as Dr. Allen was saying, it took 10 years for them to get where they are. Scrambling to get there is really not feasible.
But we are, at the same time, we have to have a backup plan if those four centers reach a burden of capacity that they can no longer handle. And I think that's unlikely, but we have to be prepared.
And for you, it creates the logistical problems of not only do you have the patients, but you have family and everyone else, and we're talking about quite a length of time here that patient could be isolated.
Yeah, our units aren't really built like the biocontainment units at Emory, where they've got plexiglass and PA systems for family. And there was a lot of talk about how therapeutic it was for those people that were in isolation being able to communicate back and forth to their families. Unfortunately, in our unit, the way it's set up and designed, not designed for this, these people would be in isolation from their families for quite a long time.
People may wonder, though, getting the patient from CVPH to Fletcher Allen, does that raise any problems? Does that raise any concerns for public safety?
I would say, well, anytime that you move a patient, obviously there are potentials. But I would say that given the process that we have in place, I feel very secure that we are minimizing any potential exposure to the outside.
I would say the threat to the community is minimal and negligible even. I think the public has to remember that even the people that were living in the same apartment with this gentleman who died in Texas have screened negative, and they're not developing this disease. There's probably a critical point at which the viral load becomes much more dangerous, and these people that are going to be transferred from CVPH or other hospitals to us are most likely not going to be severely symptomatic or critical. They're going to be rule-out patients that are going to be coming to us. But even if they were symptomatic, I think the public has to realize they're going to be in an isolated, contained unit coming to another isolated, contained unit, and the threat to the public is negligible. The threat to the healthcare worker is much more tangible and something that has really taken a lot of work to address and enlist help.
And for your hospitals, that is critical. You want to make sure your staff is safe. Not only your staff, but other patients in the hospital, but in particular your staff.
Absolutely.
Yeah, I mean, it is just as much our responsibility to take all the steps necessary to ensure the safety of our employees as it is to take care of the patients. And when employees know that those steps are being taken, they're much more willing to step in and help, and we've seen that.
And you mentioned about how the disease is spread. For the public, though, there's still many people overreact and are overly worried. Let's cover that just a little bit. This is not an airborne disease. For it to be transmitted, there has to be close contact with bodily fluids.
Yeah, and I don't want to, and I overreact is probably an accurate representation, but I think, it's human nature.
It is.
It's a human nature to be very concerned and scared about this because it's a frightening disease and the stakes are very high. So I think it's natural for the public to be concerned and scared, and I think there's been a healthy amount of fear and hysteria to some extent because it's really helped us ramp up our preparation. But I think the threat the real thing for the community to keep in mind is that the threat of flu is coming on very soon, and it's a much more real and tangible concern for our public than is Ebola. We had a ICU full of flu patients last winter and are likely to have another one this year, and I doubt that we will have an ICU full of Ebola patients.
Your advice to everyone always is to get flu shots.
Absolutely. And that was my plug.
Very good.
But there's no particular reason to get a flu shot this year in any regard to Ebola. I mean,
Well, I mean, I think that if obviously anybody, the best defense against Ebola is a healthy immune system. And if you already have influenza or some other disease or infection, it's going to make it harder to fight that off. But again, I don't think the public has to worry about that. I think they have more to fear from the flu.
What is the most important thing for the public to know?
I would say the most important thing for the public to know is that we in the healthcare service industry are serious about this, understand the risks, understand the importance, and are preparing and are prepared to take care of them. And that if they can feel that degree of comfort and security, then I think that much of the fear that may be not as tangible or not as necessary will tend to dissipate. So it's really security.
I think if the public could see the nurses and physicians coming in on their weekends off to get training for this, and the amount of work and effort that's been put in to just preparing in these last 3 weeks, they would be as proud as I am of my colleagues, and I think they would feel safe and they'd realize just how hard we are working to get this better. Again, 3 weeks is not 10 years of preparation. We're doing our best, but I'm incredibly impressed with how far we've come.
Do you believe that the specialized training for your staff is going to continue for several weeks to come?
Absolutely. Yeah, we're going to be going through iteration after iteration of this, and then, as critical care doctors, we don't even know. I don't know how I've never intubated or done a central line placement in personal protective equipment with a PAPR hood. So we're going to be moving some of this into the University of Vermont Sim Center and practicing some of these procedures with the equipment on to make sure that we can do it safely. So there's a lot more training to go on.
And speaking of practice, a number of hospitals have had drills to test their readiness. Have you had any, or are you planning any now?
We did a tabletop drill which showed some weakness and some opportunities. We are in the process of developing more intensive hands-on drills now.
We definitely have plans. The nurse director, the nurse charge in the ED has already planned some drills. These are tricky, of course. You don't want to scare the public while they're in the emergency department, so that we need to make sure that we're identifying that this is a drill. But this is the best way to prepare and make sure that people feel comfortable with what they're doing. And then after that, there are plans for additional drills of moving the patient from the ED up to the ICU, getting the ICU patient flow system down, and making sure that everybody's comfortable with it. Absolutely.
And probably for the health department, you have to constantly let the public know that these types of drills and this will be happening, and that people may see things a little out of the ordinary.
Right, and we might be participating at some level. The information might come to us because we work very closely together, and the local health department works with the New York State Department of Health in relaying all this information, helping to set up transfer or specimens, that kind of stuff. So we work very closely. We actually work on each other's drills. The state order from the governor has come out and they've requested some drills to be done. So we don't want to alarm the public. They should assume that this is just a drill, but we will be practicing because that's where we figure out what we're not doing correct and what we need to be doing better.
And we've heard just within the past few days this week, researchers are teaming up. They're rushing to try to get a vaccine. They're looking for better ways to treat this. Do you think that, much like with H1N1 and some of these other concerns we've had in recent years, that we will get to a point where we may see vaccines or certainly better ways of treating patients which will lower the risk of people dying from this, and at the same time will maybe give people a little peace of mind that it's being handled and dealt with?
I certainly believe that as we get more experience, that we will have that experience will translate into knowledge, and that knowledge will translate into action as it relates to research and things like that. Will we ultimately have a vaccine? I'm not an immunologist, so I can't really tell you for sure. Hopefully we will get something. Not so much, to be honest with you, not so much for the United States, but for Africa.
Right.
Because that's the epicenter.
Right.
And if we can get a vaccine there, then we've done tons of work.
I would say the wonderful thing about science and medicine is that necessity is the mother of invention. And I think that something probably will be developed, but I don't think it's right around the corner. And we have to be prepared for the fact that this could linger and be around for a while to come. But I think the public also should be reassured to know that, the experts at the CDC, at Emory, I've spoken to people from Emory. The thought, this 50 to 70% mortality rate is a scary number, but that's in a country with very little infrastructure and ability to deliver IV fluids, replace electrolytes, vital electrolytes that can cause, cardiovascular collapse. We have a lot better infrastructure here to treat this disease, and once we're prepared to handle the infection control part of it, which we're getting, I think that we could see less mortality from this disease in this state, in this country.
And to put things in perspective, obviously it's getting a lot of attention right now, but many more people die in this country every year from the flu.
Absolutely.
Yeah.
And we've had a handful of cases here in the United States of Ebola, and the flu yearly kills thousands.
That's very true.
And there is a vaccine to assist with that, so we want people to go out, get their vaccine, stay healthy. That's what's most important here. And see their doctor on a regular basis.
Yeah.
All right, Darwin Facto.
I thank you for bringing that up.
Thank you for coming, Dr. Gil Allen and Dr. Ken Hall. We appreciate you all taking the time to be with us.
Thank you.
Thank you.